So we are going to talk about pain management in patients with obesity. So when we look at the World Obesity Atlas in 2020, we can see that there is an increase of the obesity rate worldwide. And I live in Europe, in France, so I can see that in 2020, the rate of obesity in women is around 25%, and it will increase until 30% average in 2030. And we can see a similar predicted increase in the men. And you can see, I know there is the participants from all the world, so you can see your country and the rate of obesity that you can expect. And of course, this prevalence is also increasing in ICU, not only in the general population. As you know, the WHO classification for obesity separated several obesity classes, class 1, class 2, and class 3, with a BMI of more than 40, which means a very severe obesity. And the overall risk of disease depends also on the weight circumference. So we can see that an underweight obesity will be very different from a genoid obesity. So one of the main messages regarding pain management in patients with obesity is that all the patients with obesity are not the same, depending on the fat distribution and also the lean body mass. So finally, what is the pharmacology in these patients with obesity? We will see that it's quite complicated. So we have an increased fat mass in almost all the patients. And regarding the lean body mass, it can be whether increased or decreased. And sometimes there is a hidden sarcopenia in these patients. Regarding the heart, there is often an increased cardiac output with also an increased volume of distribution. And in ICU, there is a risk of insufficient fluid resuscitation. Regarding the kidney, at the beginning of the obesity in young people, we can see a glomerular hyperfiltration, so more elimination of the drugs, and then it can go to a chronic kidney disease, and in the acute setting, an increased risk of acute kidney injury. The liver has also some attempts, and often there is a non-alcoholic fatty liver disease with consequently altered drug metabolism, and often these patients experience dyslipidemia. And regarding pharmacokinetics, it is often altered but highly variable according to the type of the patient. So when we assess pharmacodynamics and pharmacokinetics in patients with obesity, we can say that it is very difficult to predict. So when assessing the pharmacodynamics and kinetics of a drug, it was a very nice review published this year in Critical Care. You have a methodology to follow. First, you select your medication, then you do an exhaustive literature search, and you assess several variables, a decision framework, outcomes, pharmacokinetics, adverse effects, and physicochemical properties. Then you do the literature analysis, and then you can provide dosing recommendation according to this literature. So which weights is assessed when we are talking about drug pharmacology? To simplify, we have 3 body weights. First, the total body weight. It is the real body weight of the patient. Then you have the predicted body weight. It is the ideal, also called ideal body weight. And it can be calculated using very simple formula. In men, the height minus 100, and in women, the height minus 110. And then you have the adjusted body weight, which is not the same, but which is close to lean body weight. And this adjusted body weight take into account the increase in lean body mass and also the increase of volume of distribution. So it's higher, for example, than the predicted body weight, but lower than the total body weight. So finally, which weight should we consider in patients with obesity? Regarding analgesics, our topic today is pain management. So regarding opioid, what we can say it is that first, we have to use ideal body weight or sometimes adjusted body weight, but never using total body weight. And then we do a titration and incremental dosing according to the response to our analgesics. Regarding non-opioid analgesics, we don't need size descriptor recommendation, and standard doses would apply as, for example, acetaminophen or nefopam. Regarding ketamine, it is the same than opioid. You can consider ideal or adjusted body weight for the initial dosing. So what we can summarize is that we don't need at the beginning to give higher dose of painkillers in patients with obesity than in patients without obesity. And what we know also, it is not sure, but there is some literature about it, the patient with obesity will have a lower perception of pain. There are several hypotheses to explain the lower perception of pain. You have a mechanical hypothesis. The stretching of the skin due to the excess fat would lead to a decrease in fiber density and therefore a pain threshold. The endocrine pattern is also modified in patients with obesity with increased galanin receptors that may modulate pain threshold, higher beta endorphin, and also the presence of exosome from adipose-derived stem cells that could attenuate adipose inflammation and therefore decrease the level of pain. And also, there would be a central dysregulation with higher central pain threshold in this population. So to summarize, the pain management specificities in critically ill patients with obesity, first, we have to assess pain, as Professor Jong underlined, and use NRS for communicative patient and behavioral tools such as BPS for patients unable to communicate. There is no specificity compared to patients without obesity, of course. Then, regarding the pathophysiological characteristic of a patient with obesity, he has an increased distribution volume and a modified clearance half-life. We saw the modification of the renal function. The lipophilic medications are particularly impacted, but the metabolism is impacted by multiple additional factors. You saw the heart, the liver, the kidney, the pharmacokinetics, and especially for patients in ICU where we are providing fluid loading, antibiotics, etc. And dosing recommendation for the medication. For opioids, you can use ideal or adjusted body weights and then do incremental dosing titrated to clinical effect. For non-opioid analgesics, there is no difference compared to non-obese patients. You can use non-weight-based dosing regimens. And for ketamine, you can use ideal or adjusted body weight.